We've done a number of things structurally in order to improve quality of care. But if you look at the research data, we have not seen the gains for the level of investment that we have invested in. Let's create a new structure. I'm not saying that the structures are not important. Certainly they are. But the data would suggest we're missing something. And Rob, Steve, and I, our observations, we're not the first to have it, but we have made effort to try to have the industry understand this, is that what we've been missing, if you think structure is one thing, then the other side of that is having a relational perspective, recognizing that people in organizations are connected to each other. If we think about a social network diagram, as you started to, use the word nodes, right? So we think about that in social network analysis. Which node is connected to which node? If we started to think about it that way, and therefore there are relationships, and information goes across relationships, resources go across relationships, they go across those ties, we might actually have a better understanding of why we see the patterns that we see in healthcare, both in the type of care that patients receive, but also in the interactions that healthcare professionals have with each other.
Hello and welcome to Clinical Changemakers. Today on the show we have Professor Ingrid Nembhard. She's the Fisherman Family President's Distinguished Professor and a Professor of Healthcare Management and Organisational Behaviour at the Wharton School, which is within the University of Pennsylvania. Professor Nembhard, welcome to the podcast.
Thank you so much for having me. I'm really excited that we get to have this conversation today.
Yes, me too. So I think what I wanted to jump into is a broad question. With your background as an expert in the field of organisational behaviour with this focus on healthcare, I wondered, what does healthcare do, or what is unique about healthcare, perhaps relative to other industries from your vantage point?
So I love this question because this is actually the question that I ask students to think about in my first session with my PhD students. And I also ask this question of my MBA students. I think it remains an interesting question because there's an assumption that healthcare is different, or is it? And that is something that I've really spent a lot of time thinking about. I don't know that I have the answer on that question, but here's where I am in my thinking about it. I worry actually that people think healthcare is completely different. Because if we think healthcare is completely different, then it means we're not willing to learn from other industries. And to me, that's where we may potentially be going wrong or can be going wrong. When I think about healthcare, I think about healthcare as actually confronting many things that we see in other industries. Where I think it's different is that we operate at the extremes of healthcare. Like there's no denying that the work that we do in healthcare is complex. There's variability that we can't predict all of the time. There are all these variables. What I think is that you see these variables in other industries and in other settings. Healthcare, they're up a notch. And on top of that, they're all happening at the same time. And so if we looked at any particular dimension of work or organization or relationships, any of that, I think you could actually find that in other industries, right? You could find the healthcare industry has been compared to the airline industry. They have teams. If it goes wrong, people die. Like there are things that are similar. That said, things are more compounded in healthcare. And I think that's what makes the challenge more formidable and why we have struggled so much. But I worry about saying it's completely different from other industries.
Yeah, and it makes me think about why does that question get asked? Meaning that is the first assumption as a professional group, with a narrow expertise. But as you say, you can lift elements of that into other areas. And so I guess there's something curious about the question even being asked that imposes an idea that healthcare is unique. What has been your experience in that space of engagement with healthcare and healthcare professionals, the uptake perhaps of the lessons learned in these sorts of spaces?
I think that healthcare professionals are increasingly interested in learning. Many healthcare professionals that I speak with have now they realize that there's a difference between operating in the clinical space and doing the clinical work, and that work actually occurs in organizations. And that for me is a sort of what I've observed in my career, sort of a watershed moment of, oh my goodness, we work in organizations. And if we work in organizations, then things would be thought about differently. We'd start to think about operations. Oh, it actually does matter. Supply chains actually matter. Where we even architecture matters. If we think about team dynamics, oh my goodness, there's a patient care team. I'm not the solo clinician responsible for this patient. I actually need to think about what do we know about working in teams? Oh, I am not enjoying my work because of X, Y, and Z factors. Most of the time, or much of the time, it's not necessarily clinical. The frustrations of healthcare workers, from what I can tell, a lot of them are administrative. They're organizational. They still very much enjoy the work and find the work rewarding and important. Where they are struggling is because the organization and the systems are not working to make life easier for them to do the work that they want to do. And so I feel like in the last 10, 15 years, I increasingly confront clinicians, MD physicians, family practice, specialty, what have you, nurses, respiratory therapists, pediatricians, what have you. I increasingly see them coming into the world of, I think I need to take an executive education class. I think I need to learn something about how organizations are supposed to run so I can make it better for my organization to run so that patients can get the care that they should receive. So for me, my observation is how much people are now realizing that they need to improve the organizational side in order for the care side to actually function well.
Where do you see that this should or could sit in clinical training? Because it sounds like perhaps people are getting to a stage in their career where they've gotten through to the other side and they're realizing, hey, I'm having to manage teams, I'm having to lead, I'm having to do all these things. There's something to learn here. There's something for me to do. And I wonder perhaps we need to go a little bit further upstream to instill elements of this type of thinking. What's your take?
Right, I hear from the enlightened that that is the dream, right? That we would change medical education in a way that it would probably deal with two things better than it does today, at least two things. One is it would very much focus on interprofessional training and not just one class, but actually having people more regularly interact in the care team and develop those relationships. Understand that we're trained in different ways. We might use different terminology. We might mean the same thing, or we might be using the same term, but using it in a different way. We might privilege information differently across specialties. And so when I hear people talking about the difference or what could be, that's certainly one key thing. That would change a lot of the dynamics that we care about as organizational behavior scholars in terms of how do we communicate with each other? How do we handle conflict management? How do we manage the flow of information amongst each other? Those are things that I think would come from that kind of training and revisiting training. The other component that I think I hear and would advocate for is more training on working in healthcare, just being in the industry. So I think students in many programs do receive some information about the healthcare industry, but perhaps not enough given how complicated the industry is. Part of it is about learning the industry, and then part of it is learning to run and lead organizations in that industry. And not everybody is going to pursue a career in which they are, the CEO, the CMO, the CNO. Not everybody needs to hold those roles, nor should everybody have those roles, right? But everybody can be leading where they are. And that's a different skill set than diagnosing a patient, treating a patient, making sure you're sort of operating at that space. And so I think if we could, put some of that education a little bit higher up, that would make a difference. I have increasingly I'd say maybe about a third of my classes now are MD, MBA students. These are students who have already said, I get the feeling from having done a couple of rotations that I am missing part of the picture. I keep hearing about this thing called value-based care and that's going to affect the way I practice care, but I don't actually know what that is. And I don't know what the implications are. And I don't know what the requirements are for me or the organization that I might operate in. or the organization that I might choose to run down the road of all of that. So I'm going to take this year and a half to go and learn some of that so I can feel a little bit more prepared when I'm out in the world. That's not every clinician, but could one or two classes be built into the curriculum that would allow people to feel a little bit more power about when they enter the field? Probably.
From my personal experience, this whole area was a blind spot to me. When people were talking to me about leadership and management, I sort of had, 5 bullet points in my head. Oh, that's, someone out there being courageous, standing on a big hill and what have you, and learning that there is so much more here for us to learn to entice those people who may have an interest already early. And then, as you say, around understanding that you are not an island, that you are working in a team, and that actually you all have a part to play. Sometimes you're the lead role, and sometimes you're the tree in the corner, and that's okay. But the other bit that I wanted you to elaborate on, if you don't mind, was you said that it would be great for perhaps early stage healthcare professionals to learn about the work. And my mind was thinking about two separate things here. One was the broader context of healthcare and the system, how people get paid and how people get covered and those kinds of elements. And then another part of my brain went back to when I was a junior and thinking about how I actually operated in this system, because a lot of my work was actually not as clinically orientated as people might assume. It was organizing, it was ordering, it was communicating to the senior person at the right time in the right way. It was all of these other types of skills that aren't purely, biomechanical and aren't purely patient-facing either.
When I teach, I try to do both of those, right? So for those who are more junior, they can envision a path in which they're going to go from what I call sort of the producer to the manager, right? And so your description of I need to speak to someone who is more senior than me to raise an issue, whether it is a problem or a suggestion, doing that effectively is actually quite hard, and yet it's critically important. And we see many instances in which people just make the choice not to do it because they don't know how to do it, or they are bold enough to do so. And what they experience on the other end of that is not pleasant. And they learn an important lesson that that is not that will not be appreciated if they continue to do that here. So there becomes a question about, can we help people learn to deliver messages in ways that are likely to be received well by others? That's one direction. And then there is the other part of being the type of person who can receive that information well. And so we have to teach both sides of that. And I'm not sure that we do that well broadly as yet for many people. Both of the ones that I picked up on that last one, but I think both of them are important skills. A lot of this is skills and development, and we haven't really built up our workforce in a lot of the skills that they would need to be effective working with other people.
Yeah, you're giving me some flashbacks of those types of interactions, and definitely not all of them being pleasant. It did make me think about how some of those interactions had a cascading effect. So perhaps this person was extremely busy, had other priorities. Perhaps it was in my delivery or what have you, and whatever I had tried to hand over or communicate had failed. It did make me think about the networks that potentially start becoming created within the hospital that perhaps are unseen and probably are spoken about, but aren't necessarily on an org chart of, well, this person's nice, they will, accept your patient, and this person's not so, won't accept those types of patients. And so I can imagine from a manager and a leader's perspective, they look at the organization and they look at the departments and they say, well, these people do this and these people do that. But actually underneath that, there are these nodes and connections that really, really shape the performance and the outcomes in that hospital. I wondered if you could talk to a little bit about how to think about networks within these types of organizations.
That is something that I think we need to be paying more attention to. So your experience of, oh, I can, maybe people are connected in ways that are relevant to what is able to be achieved in organizations. And my colleagues and I, so Rob Burns, who's here at Wharton, and Steve Shortell, who's at UC Berkeley, we wrote a paper, well, now it's about a couple of years ago, where we actually put forth this idea that if we wanted to see better and more integrated care, more coordinated care in health systems generally, we would actually need to move in the direction that you just said, which is we need to pay more attention to the networks that operate between people, and the networks that operate between organizations. And not just healthcare organizations, but organizations that interact with healthcare. And so you can imagine a multi-layer in which, multi-level situation in which networks are actually quite important to the care that we deliver. That view is actually considered quite novel, even though we live in a world now where people talk about social networks all the time, right? What social network are you on? Are you LinkedIn? Are you on we're used to thinking about social networks, but we haven't thought as much about how social networks are operating in healthcare and how they might be relevant. Perhaps because we think that's in our social outside of workspace or in our networking for job space, versus thinking about the way people are connected has a lot of implications for what is achievable for them. Largely when we thought about how we're going to improve healthcare, certainly true in the US, but I think also true in other countries, we have thought about let's change structural things. Let's vertically integrate. So let's mix the specialty group should buy the primary care group, and that will just solve the problem magically. If we just buy them, it goes away. We also look at structures like, oh, what if we gave them more incentives? So what if I say, Jono, if you see 20 more patients today, here is what we will give you. Or if you refer these patients to the hospital instead of treating them in your own practice, here is the benefit. We've done a number of things structurally in order to improve quality of care. But if you look at the research data, we have not seen the gains for the level of investment that we have invested in let's create a new structure. I'm not saying that the structures are not important. Certainly they are, but the data would suggest we're missing something. And Rob, Steve, and I, our observations, we're not the first to have it, but we have made effort to try to have the industry understand this, is that what we've been missing, if you think structure is one thing, then the other side of that is having a relational perspective, recognizing that people in organizations are connected to each other. If we think about a social network diagram, as you started to use the word nodes, right? So we think about that in social network analysis. Which node is connected to which node? If we started to think about it that way, and therefore there are relationships, and information goes across relationships, resources go across relationships, they go across those ties, we might actually have a better understanding of why we see the patterns that we see in healthcare, both in the type of care that patients receive, but also in the interactions that healthcare professionals have with each other.
I can imagine for many healthcare leaders, when they look at an organization and the structure, hear what you say, and it makes a lot of sense. How does one promote, support, enhance, probably firstly unearth what that network is, and therefore understand it well enough to support it in the areas that perhaps it's weak and learn from the areas that it's strong?
It is a challenge, but perhaps it is a challenge that is getting easier, right? So in some sense, you can relationally map. There are people who've been doing social network analysis for decades now, right? And you can ask questions about that. Historically, that's been a pretty manual process to be able to do that. Whether you ask people who are in their networks, are they a friend? Do you get technical expertise? Do you get advice from them? What does it you get from each person in your network? We can do that manually. Now we live in an era, right, where we can take unstructured data and we can actually see the networks, right? So now we live in a space of AI where you can use the electronic medical record and you can actually see who, and you can see the referral patterns. You can see how often we are interacting with each other. You can see how long it takes for that interaction. You can see, who did we send a bill to? How much are we interacting? And which person in our organization is interacting with which person in their organization? There's a digital footprint for almost everything now, right? You and I are having this conversation, and all of a sudden the internet knows that you and I are connected. Whereas 2 years ago, we were not connected. So it is actually becoming easier to understand what some people like Jody Hoffer-Cattell, who's at Brandeis, her team, they have developed relational analytics. They show they have procedures for doing relational mapping. And many organizations, particularly in healthcare, are starting to do that kind of analysis using the frameworks that they have put out. There are formal ways to do that now. And there are also just your data is there and you can look through your data and you can find the relationships that are existing. And you can also find the gaps. You can imagine doing a map where Jenna said, okay, I know that my patients need in a week, I see patients that need access to food resources. They need transportation. They need housing. They need a referral to X, Y, and Z. And you look at your portfolio and you say, you know what? I don't think I have somebody who's able to do X, Y, and Z for those patients. You've now identified a gap in the network. How do you close the gap? Is somebody in your network who might have that access point that you don't really have? You would start to think a little bit differently about what kind of network is necessary for you to work well and for your patients to receive the care. I think it's an opportunity. I would love to see more people doing research in this space. I would love to see more people trying and practice to leverage their networks as intervention. And it can be different levels, right? We can talk very broadly, but we can also talk about leveraging, who are your podcast is called Change Makers. Like, who are the change makers in your social network? You probably know who they are. Who are the opinion leaders? Also, who are the naysayers? And therefore, what role would they have if you were trying to roll something out? There's research about that can be really helpful.
So there's elements of this that feel a little bit retrospective. And I wonder how people could turn this into more prospective. So what are the fertile grounds that make an effective network? And my brain very simply tries to think about the combination of, structure and culture coming together. What would you say would be best practices or areas that people could think about if they were to, go from looking back to understand to trying to set a path that fosters great networks within a healthcare organization?
We should probably think about this at different levels. So imagine that we are within a particular practice, group practice. We might then and there's always going to be a little bit of a retrospective because the tie exists or it doesn't exist in stage one, right? We might think about, how do you bring that person in? This is not online teamwork, right? I realize that I need to know Jonah for something. How do I get him involved? How do I make a connection to him? There are opportunities where we create, for example, I've seen organizations think very strategically about what their quality improvement team looks like or what initiative they launch, and choosing initiatives that necessarily bring individuals or organizations together that historically have not been together. But you need them in the next round, right? So thinking about that, I think, is one way of doing it. Like, who do I need in the next round? Okay, well, if I need that, then how do I go about it? Sometimes we go about it by it really is, the open call. Like, I don't know you, but I think we have something that we should conference about. Sometimes it is thinking about the networks and the in between, right? So I am connected to someone and you are connected to someone. How can that person be a bridge for us? How can that person also actually help us mediate if we're so different that it might not be so obvious why we're having this conversation? But we are in the network together. We just don't realize it as yet. Some of that, I think, we can think about how to make that happen. Sometimes actually it's just, I know you said, we don't want to look retrospectively, but sometimes it's about breaking the network too, right? Which is, we can think about two providers, two organizations that have had a very strong tie, but in all honesty, that tie should not exist, or it should not be as strong as it is. It's causing us to miss out on another tie that would be more beneficial. A lot of this is actually analysis, right? It's analysis of what your relationships look like. And that is a starting point. It is also on the backside of that, if you're not looking at the relationships, it is looking at whatever opportunity you have before you and saying, what do I need to have that happen? In my class, I require all students to think a little bit about strategic problem solving. And I make it very clear to them that sometimes strategic problem solving is solving a problem that you currently have. And sometimes problem solving is realizing that your future state is different from your current state. And that's a different kind of problem. That's an opportunity problem. But you can still approach them in the same way.
What you got me thinking there was around, being problem orientated is very helpful to focus and to gather people around. But there are known problems, there are unknown problems, and sometimes a lens on relationships can be a way to help, maybe not exactly future-proof, but maybe reduce or mitigate any impact of unknown problems that could be around the corner for either of those groups who are connected.
For me, relationships are important. I spend most of my research career thinking about the work environment for healthcare professionals. A fair portion of that is thinking about this idea that you probably are familiar with of psychological safety, and the idea that we need to create work environments where people can take interpersonal risk. When we talk about interpersonal risk, we're talking about things like raising a concern, offering a suggestion, offering the half-baked idea, right? Where we don't even know there's a problem. We don't know there's an opportunity, but something in our mind says this is something that we should be talking about with a group or with another individual. If we feel psychological safety, then we can raise all of those things. We can be forward looking and deal with all the uncertainty. We can also look backwards and deal with the failures and the experiments and all of those things. We can deal with both the forward and the backward because we feel safe to do so. Feeling safe means we're not going to be punished. We're not going to be reprimanded. No one is going to speak poorly about us. We're not going to be demoted. We can bring things that are work relevant to the workplace. And that allows for many different things to happen. Sometimes people will confuse psychological safety, meaning that, oh, we're friends and we're nice to each other, and they're focused on that part of the relationship. Psychological safety, though, is slightly different. Not that you can't be friends and have psychological safety, but it really is about having more of this idea that the relationship is filled with respect. And if it is filled with respect and a willingness to work together, then we can engage in tough conversations. So it might actually not feel very pleasant. The way we think about relationships are pleasant. It might not feel very pleasant because you actually are going to have conflict as you think about, is that what we really need to do? Do I agree with you that that is a problem? Do I think that that suggestion has merit? Wait, that's a really wacky, creative, but wacky idea you just presented to us. What do I do with that? If you're in a space where there's psychological safety, you can have those conversations. And so the difficulty of learning together can actually be easier. The difficulty of failing together can be easier. Relationships are near and dear to me. I think they matter. They matter because of what they allow us to do. But those relationships have to be filled with respect for one another. They have to be filled with an appreciation that we're all moving towards the same goal together. We're trying to do that. We're not undermining each other. We're trying to reach a goal together. If that's within the relationship, then I think a lot of things are possible.
Yeah, and I think that there is something in, it's not always that moment or that problem or that scenario that you're trying to solve for. You're trying to build, as you say, sort of robust relationships so that anything, even perceived or otherwise, that's coming down, because in an operating theatre or an ER, even the perception of an issue or a danger may be holding somebody back or changing somebody's behaviour. And so even just to know that that is a worry, to say, hey, I hear you, it's actually not a problem or what have you, can help that team, and then also build that trust such that when things are, going pear-shaped, everybody's eyes and ears are open and mouths are ready to point things out, because again, we can't be those kinds of islands. I wanted to ask a question about how this is enacted in practice. For myself, learning about these concepts, I've been thinking about almost, and this is going to come off a little bit wrong, but a scripted way to build in the practice so that I'm actively doing this, because I think there is something in my mind that consumes this quite readily, but then my actions have to be practiced. And I feel like the only way to do that is to think about, how can I be explicit about this to people so that I can build the muscle memory and the experience to be active in it, but equally get it out of my mind and actually onto the table to be scrutinized or consumed, maybe.
I think there are two domains of answer to that question. The first is, I think there actually is something very valuable in voicing it, right? So it's not just happening in your head, but having that conversation and recognizing it. So, for example, we were just talking about psychological safety, and we could imagine a scenario in which you as a team leader raise that concept and you give people that term so that everybody is on the same playing field about what that is. Right? So it's not just in your head anymore and you're trying to do it, but making it something that everybody has to think about, and collectively we understand, oh, Jonah's responding in that way because this is something that he values and we as a team should value. But then you asked about what specifically do we do? So I think one is just to voice it, right? So this is how we should operate. This is the type of culture. You said there's something about it, right? The word we use is culture, right? You're building a culture in which people operate, and it can be positive. The specific actions, though, typically when I teach it, there are 5 that we think about, right? So if you're a leader who wants to nurture this kind of environment where the relationships enable the work, largely because they're psychologically safe and productive for teamwork, one thing you would do is frame whatever you're working on as teamwork, right? I'm not an isolate. You said that. I'm not an isolate. So what if we just recognized and said, we are actually trying to achieve this as a team, and I recognize that no single person here can do this on their own. There is no patient that is cared for independently anymore. We're long past the days of the doctor, one person showing up to your house and caring for you. We're long past that now in most places. So we need to work as a team. So let's frame the work as a team. That means everybody has a role. 2 is being accessible. So for people to believe that you are interested in what they have to say and their perspective, you have to be accessible for them to share that perspective. That can look like many different things, whether it's, you pause in the operating theater to say, I need to hear from everybody. You can be accessible. You can have open office hours. You can have Zoom hours, what have you, but so that people know that there's an opportunity to voice. 3 is inviting it, right? So not just having the office hours, but when you're actually in communication with people, are you inviting their perspective rather deliberately? 4, I think we're 4, or 3, is really how you respond, right? So many of us have been in situations where we decided to we received the invitation, that felt really wonderful, and then we gave something in response to that invitation. We shared our idea, we shared our visions, we shared the possibilities, and the response to that was not a positive one. And that teaches many people a lesson pretty quickly. So it really does matter how you respond. And then I think the last one I want to share is making sure that you are demonstrating in your own behavior, that you are role modeling, that you are human and you make mistakes. People are really attentive to that from their teammates and their leaders, particularly from their leaders. If you are able to say, I don't know the answer, or I made a mistake, people will remember that. They'll know it's okay to speak up with ideas. They'll know it's okay to make mistakes. those things make a difference. Those sequence of activities can make a difference. How do you make them hardwired? I actually, when I teach executive education, I have slides, right, where like, good conversations are both statements and they're questions. So what kind of questions do you ask in team meetings? They're little cheat sheets. You can have 5 questions and you can keep that on your desk and say, oh, did I ask any of these questions in this meeting? Did I broaden the conversation? How did I deepen the conversation through my questions or my statements? I think that's for if it's not muscle memory yet, having a couple of sentences, having a couple of questions that you use pretty regularly until it becomes muscle memory, I think it's something that we can all do.
Now, I wanted to jump the conversation just a little bit to some of the writing and research that you've done around innovation. And one particular area which I thought was quite interesting was dispelling a myth, perhaps, of this idea that creativity and standardization in healthcare are incompatible, and that from your perspective, they can be complements. I wondered if you could talk to that really interesting approach to thinking about this.
So, one of the things that has been true, at least in the United States, but I think true in many countries, is that there's been a real push towards standardization. And if you think about it, that makes sense, right? Standardization means that every patient would receive what we hope is evidence based care. That seems like a win. If we standardize, right, that's quality care. If we continue to standardize, maybe we would also get some cost efficiencies. If we standardized, we could also do things in enough volume and repetition of the same thing that we start to learn and improve, and we have the option to get better over time. But standardization has this idea that like we're going to do the same thing over and over and over again. Meanwhile, in other industries, we hear about, oh, we're creative, right? And creative is the idea of like, I mean, if you think about it, like we're not standardizing, right? We're deviating. Creativity assumes that there is going to be some variance increase, as opposed to standardization is something we pursue to decrease the variation. Standardizing is about decreasing the variation in our processes. How can these two things possibly go together? My colleague Una Lee and I have written about this as you said, they're complements. Because once you standardize, you can see the times that you're going to be able, you can see when you're varying from that standardization. And you can see the opportunity like, oh, you know what, we need a solution because that doesn't fit our standardized rubrics. And over time, if you're using your creativity, you develop new innovative ideas. And some of those ideas you actually want to standardize so that they can become the best practices that we use and we deploy to patients and we get the cost efficiency and the quality gains from. So there is this rhythm of let's standardize, let's then look for the deviation. If we're standardizing, we can then know when we've made some creativity gain, or we can try to be creative and see what happens. Is that better or worse? And when we have that creativity, we can then use that as a cycle for then having the ability to standardize and move forward. So for us, those two things actually come together quite nicely. I don't think we'll ever get away from this idea, and we shouldn't, that healthcare is a field in which we face sort of another tension, which is standardization and customization, right? That's the other one we talk about. We want to standardize, but every patient is different. So we need to customize care for our patients. Yes, absolutely true. They're married together. We need to standardize what we can standardize and customize what we need to customize. And so we need to be able to do both together. And that, I think, is actually one of the managerial challenges that healthcare faces, is being comfortable with this idea that we need to do both and setting up our systems to be able to do both.
What I love about that, lots of different reasons, but one is pulling almost two camps together, because sometimes you can see clinicians sitting in the, every patient I see is different. My patients are so complex. I must have to work in the grey areas in the at the forefront of these application of practice, and then managers trying to create consistent outcomes, to hit particular maybe quality metrics, etc. And so those two groups being in sort of philosophical tension, and barriers, and that network might be chopped down the middle because of those perspectives. And so bringing that together and giving each of those elements a pathway forward. So if we standardize, we can understand where we can innovate and change, and then build that back into our standardization and feed that back across the group there. I think it's a really great way to think about it.
My hope is that more organizations will see that. I think COVID allowed us to see the possibility for these two things to operate or how they could feed each other. Right. So we started out trying to apply our standardized practices during COVID and quickly realized that that was not going to work in many instances. Nobody wants to live through COVID again. But what we saw in the healthcare space was that healthcare workers, healthcare organizations could actually be quite creative. And that creativity is what allowed organizations and patients to live. And that creativity, hopefully, in many organizations, has now become standardized practice. Some of the things we hadn't thought to do before. That's just too creative an idea, right? What if a patient gets hurt? Well, wait, we can do creativity well in healthcare. We can actually do creativity well, and we can learn and therefore make that part of our new practice. So I'm hopeful that a lot of organizations saw the potential. I am also very worried that it's easy to go back to where we were before, that has happened in many organizations, that we just want to be like we were before. And in trying to be like we were before, we've maybe given up some of the positives from that time.
In one of your papers around responding to COVID-19 and lessons from management research, you talk about managing operations creatively. I wonder, what can leaders, what can systems do to foster that, to build a culture where those sorts of things can thrive, as opposed to going back to the old days?
So one of the things that we saw during COVID is structures put in place that allowed for information to flow pretty regularly, and information to flow from the front line all the way up to the top. Whereas before we had, like, this group can talk to this group can talk to this group, maybe we'll have a town hall and we'll hear something from, well, that information can go between two groups at different levels. But we saw that bridging across levels in organizations during COVID. That's one thing that we could maintain as we move forward. How do we allow those opportunities? So there are organizations, many organizations, and they're still doing it, where they have tiered huddles, where they allow someone from this, we have the frontline huddle, then that huddle moves up, someone from that one moves to the next tier level, and it is allowing the information and the ideas to bubble up through the organization. That makes you more nimble as an organization, right? You're getting information at a faster pace than you had before. I think leveraging that, also those small groups, right? Teams are how organizations learn. Teams are how creativity happens. So creating those pockets, those groups. We don't want to make groups insular, but we want to create those groups where people can readily exchange ideas and then make a pathway for those ideas to move up through organizations. Those are things that we can do pretty readily. We can also think about how we bring in different groups to that conversation. Not to take away from our supply chain inventory people. We didn't pay that much attention to them before COVID. I think that's just being honest. We didn't pay that much attention to them. Then we saw, that actually matters. And their creativity really matters. And so realizing that the team is bigger than the team we thought it was is important, making sure that we're having those ideas. We often hear things. So in the work that we do on creativity, we have tried to collect creative ideas both from healthcare workers and from patients, right? These are the people who are the front lines of care. They are experiencing care. They often see the opportunities for creative ideas in the operations of the daily workflow of healthcare. The challenge has been getting those ideas, getting those challenges into the system, having them voice those ideas, and then having them get to the system where they need to be.
Yeah, I think that's a great point around how to get those voices into the system. You had me reflecting on, during COVID, getting swabs and vaccines and all these things. We had some logistics experts come and speak with us, and we were just like, wow, you guys are incredible, like yes type of thing. And it was, as you say, we hadn't had them at the table to begin with. They knew the problems, and we hadn't let them in. So that was a big learning point for me. Professor Ingrid Nembhard, this has been a really fascinating conversation. I really appreciate your time, and I think I'll maybe let you have the rest of your day.
Thank you, Jonah. We covered a lot of territory, and I was happy to talk with you. You made me think about some things I hadn't thought about in a while. So thank you so much for having me today. It was fun to chat with you.
And that brings us to the end of the podcast. If you want to go deeper about any of these topics or join in on the discussion, visit our website, clinicalchangemakers.com, or our YouTube channel. Finally, if you enjoyed our work, please give us a rating and share your favourite episode with a friend or colleague. Until next time, take care.